Atorvastatin side effects. My name is Dave, I'm a pharmacist, and atorvastatin is the generic for Lipitor. The most common side effects fall into two categories: gastrointestinal and musculoskeletal. And the drug company likes to point out that there's very little difference between atorvastatin and placebo in terms of side effects. Now, is that true? I would like to know. And when I look into the research, I see that myopathy occurs in about 5 to 20% of people who take a statin drug. Now, what is myopathy? It's an umbrella term basically for muscle symptoms. And I categorize these muscle symptoms into three categories. And the least serious is myalgia, which is muscle pain. The next most serious would be myositis, which would be something like muscle symptoms such as pain with elevated creatine kinase. Creatine kinase is an enzyme that's dumped into the bloodstream by a damaged muscle. So that's basically chemical laboratory evidence of actual muscle damage. And then the last one there, the most serious form of muscle damage, is rhabdomyolysis. And that is characterized by a marked elevation in creatine kinase and also myoglobinuria, which is like a red-brown discoloration of the urine. And we'll look at that and talk about that more on the next slide. So these are not only in order of severity, myalgia, myositis, rhabdomyolysis, but also, fortunately, in order of frequency. So myalgia occurs relatively commonly, and the rhabdomyolysis is very rare. So what is the overall risk of myopathy? According to this study, 27.8% of people who take a statin will experience some sort of muscle symptoms. Now, if you look at some other literature, you're going to find the range is usually between 5 and 20%, just to give you an idea of the risk of muscle symptoms. And then in this paper cited at the bottom of the slide, you'll see that simvastatin 40 milligrams had a 50% risk of muscle symptoms, whereas rosuvastatin 10 milligrams only had a 10.8% risk of muscle symptoms. So the risk does vary based on the drug and based on the dose being used. And I did not address atorvastatin directly here, but it falls somewhere in the middle. Rhabdomyolysis. Here's a urine sample from someone with rhabdomyolysis. As I said, it's a red or brown discoloration of the urine, and the reason the urine is that color is because there is a protein from the muscle called myoglobin in the urine. Now, what happens here? Why is rhabdomyolysis dangerous? So the myoglobin from the muscle breakdown goes into the bloodstream, and the kidneys are the filter for the blood. And what happens is this myoglobin is it comes into contact with the kidneys and it damages the kidneys. It's toxic to the kidneys. And so what can happen in the worst case scenario is something called acute renal failure, which is kidney failure, and your kidneys basically shut down. And that's obviously a life-threatening situation because your kidneys are involved in all sorts of regulatory processes, and they keep your blood and your body in homeostasis in various ways. Here I'm going to talk about what causes the muscle symptoms with statin drugs. What's the deal here? What's with all the myalgia, myositis, the rhabdomyolysis? We don't have a firm answer regarding what causes that, but here's a quote from UCLA Health. It says that some studies have shown that statins decrease the concentration of coenzyme Q10 in muscle tissue and in the bloodstream. And the hypothesis is that if you decrease these coenzyme Q10 levels, what you're doing ultimately is reducing the production of energy in muscle cells, and consequently they will not function as well, and that could lead to muscle aches, weakness, or inflammation. So why does CoQ10 reduction result in reduction in the production of energy? CoQ10, coenzyme Q10, is a critical component in energy production in the mitochondria. The mitochondria are the energy production powerhouses within the cells in the human body. Here's a graphic of the biosynthetic pathway of cholesterol. Cholesterol is on the bottom right. And the way statins work, statins are also known as HMG-CoA reductase inhibitors. So this is HMG-CoA reductase right here. It's not really depicted, but you could imagine that it's the arrow there between HMG-CoA and mevalonate. We inhibit this with a statin, and what that does is it reduces the production of all of these downstream chemicals, including cholesterol, but also including all these other things. Now, so cholesterol is the target. That's what we're trying to reduce. Now, do we want to reduce all these other things? We aren't 100% sure. It seems like the benefits of statins are pretty clear, especially in people with established cardiovascular disease, or particularly in those patients. But ubiquinone, we are reducing the synthesis, the biosynthesis of ubiquinone, which is another name for coenzyme Q10. So could that be a problem? It could. Now, rare serious side effects. I showed you the common side effects: gastrointestinal, musculoskeletal. So what are the rare serious side effects? We've already talked about one of them. It's the muscle damage that results in the condition rhabdomyolysis. Now, what is the actual quantified risk of that? Okay, so rhabdomyolysis, very dangerous, life-threatening, but the risk, if you're only taking a statin, is only 1 in 22,727. So very small risk. Now, I do want to point out, that's if you're just taking a statin. If you're also taking a fibrate, which would be a drug like Tricor or fenofibrate, or Lopid, which is gemfibrozil, those are both fibrates. If you're taking one of those in addition to the statin, and you're elderly, and you have diabetes, according to this source number 1 at the bottom of the slide, your risk of rhabdomyolysis has increased a great deal, up to 1 in 474. So it's still pretty rare, but you can see how with aging and with comorbidities and with additional drugs that like fibrates can potentially increase the risk of rhabdomyolysis as well. So you're kind of stacking a drug that can cause this on top of another drug that can cause this, thereby increasing the risk further. And so that's the situation there. So liver damage, what's the risk of liver damage? Well, liver damage can be minor, it can be major, but as an umbrella category, liver damage, elevated liver enzymes are the marker of liver damage, by the way, and that occurs in up to 1% of people who take a statin. So what can you do to mitigate your risk of liver damage? Just abstain from alcohol. Don't consume alcohol, because that increases the risk of liver damage. The last rare serious side effect is diabetes, and it's really, I have a hard time really calling it rare. It looks like up to 2% of people who take a statin, and this would be like a high dose statin in this case. Lower doses are probably going to impart lower risk of diabetes, but up to 2% may develop diabetes, and they may otherwise have not developed diabetes. So it's kind of a thing where you have to weigh the benefits versus the risk. Is your cardiovascular risk substantial enough to justify the use of a drug that may increase your risk of developing diabetes? So that's a question you and your doctor have to figure out. So what is the probability of these serious but rare side effects as an umbrella category? So in a study of more than 10,000 patients, 1.8% of those taking atorvastatin 80 milligrams, which is the highest dose per day, had a serious adverse reaction, and 9.9% quit taking the medication. And that's compared to those who were taking atorvastatin 10 milligrams daily, where 1.4% experienced serious adverse reactions, and 8.1% of those taking the 10 milligram dose stopped taking the medication. Now, the question I have is, why did they stop taking the medication, those people who stopped? Because almost 10% in both groups stopped taking it, and there's not really an explanation provided. My suspicion is some sort of myopathy, some sort of maybe myalgia or myositis. So that's my suspicion. But the other numbers there, that gives you an idea. So we said, up to 2% for diabetes, up to 1% for liver damage, and then a very rare, very small percent chance of rhabdomyolysis. But if you take all those rare serious side effects together, what is the probability of experiencing a rare serious side effect in general? So it's 1.4% on atorvastatin 10 milligrams, and all the way up to 1.8% for those taking the highest dose, which is 80 milligrams. All right, so here's another study. It's called SPARCL, Stroke Prevention by Aggressive Reduction in Cholesterol Levels. This was 4,731 patients that were followed for almost 5 years. And this also looks at serious, rare adverse effects of atorvastatin. So liver damage, 0.9% of those taking atorvastatin 80 milligrams daily experienced persistent elevations in liver enzymes compared to just 0.1% of those in the placebo group. So subtract the placebo group, and that's 0.8%. So roughly the added risk of liver damage from atorvastatin, the highest dose, appears to be 0.8% in this study. And then muscle damage, 0.1% of those taking atorvastatin 80 milligrams, the highest dose, every day, experienced elevations in creatine kinase compared to 0% of the placebo group. So you know how I pointed out about myositis being the muscle symptoms plus an elevation in creatine kinase. Now this is not necessarily rhabdomyolysis, but this is sort of perhaps a precursor to what could eventually progress if nothing was done to intervene. So basically, 1 in 1,000 experienced basically what I was calling myositis. And then diabetes, you can see the difference in the percentage of people who develop diabetes. In the placebo group, 3.8% developed diabetes, and the atorvastatin 80 milligram group, 6.1% developed diabetes. So that's a 2.3% higher absolute risk of developing diabetes in that highest dose group. Another note I want to make about atorvastatin is a drug interaction with grapefruit juice. So the key point is just do not consume more than 1 liter of grapefruit juice per day if you're taking atorvastatin. And the other note I want to make about pregnancy and lactation, atorvastatin is not supposed to be used in women who are either pregnant or breastfeeding, because the baby actually needs to produce a lot of cholesterol, so you don't want the baby getting any cholesterol lowering medications. That's all for today. Thank you for tuning in. You can check out my website, daverx.com, and I have a new book, After Ablation. So if you or anyone you know has AFib and they would like to do everything they can to minimize the risk of a future episode of AFib, or if they've had an ablation for AFib and they want to reduce the probability of recurrence to the greatest extent possible, they can purchase my book, and there's a course on there too, and that would be beneficial. Thank you for tuning in. See you next time.